my pleasure today to introduce our speaker, Heidi Spratt. She's a tenured associate professor at the University of Texas Medical Branch in the Department of Preventive Medicine and Population Health. And she is primarily working as a collaborative biostatistician. She is a past chair of BIRD, the Biostatistics, Epidemiology, and Research Design Special Interest Group. It's a BIRD-SIG group for the Clinical and Translational Science Association. Since 2014, she has been the secretary of the Association for Clinical and Translational Statisticians. She's actively involved in a Nation COVID Cohort Collaborative, which is well known by the acronym N3C, where she co-leads the Clinical Scenarios Working Group. Dr. Spratt has served as PI on an NIH K25 award, as well as an NIH R03, and presently supports multiple investigators with their grants and collaborative projects. So Heidi, welcome, and thank you for agreeing to take on this webinar.
Great, thank you so much for the introduction, and I think we will go ahead and get started. So you should see my N3C slides at the moment. Okay. Great. So as Dr. Fernandez said, I am one of the co-leads for the Clinical Scenarios Working Group within the N3C, which stands for the National COVID Cohort Collaborative. And I understand this seminar series is to sort of give you guys an idea of existing data sets that researchers nationwide have access to, and a little bit about those data sets, how to use them, what type of data they contain, as well as some of the issues working with those data sets. So that's what I'm here to present to you today. I'm very informal in how this goes. So if you guys have questions along the way for me, you can either use the chat feature or unmute yourself and ask. So N3C is sort of a partnership with NIH, as well as CTSA entities and NCATs. It has also partnered with several different common data models, the ACT network, PCORNet, TriNetX, as well as Odyssey. And so what we've got here is the problem that N3C is trying to address is that the US really doesn't have any central data repository. We don't really even have a standard data format. For instance, different organizations use different systems, and generally each organization has its own data warehouse for internal use. And there's not a whole lot of consistency from one entity and one institution to another. So some progress has been made in that there are several different common data models out there. There's PCORNet, there's ACT, there's TriNetX, and there is I2B2. But each of these have slight differences and slight nuances. So how are we able, and how can you combine data from multiple disparate entities? That's one of the things that the N3C is trying to tackle. And they're doing this through a federated model of sorts, where different entities are pooling their data together. And so what N3C has actually done here is to recruit multiple different data partners around the country to collect COVID-related data. So all of this data is publicly available, but it has the caveat that it is somehow related to COVID-19, meaning all the information within N3C is either from individuals that have been diagnosed with COVID-19 or individuals that have had a test for COVID-19. So it is not a completely fully representative data set, but it is very specific for COVID-19. And so to be able to connect all of these different common data models, N3C has been working with a harmonization process to try to harmonize the data from each of these entities. And the harmonization model that they chose to use is this OMOP framework. And the OMOP framework, I forgot exactly what OMOP stands for at the moment. It's in one of my following slides. But basically, OMOP is a framework for how the data is harmonized from each of the different common data models. And it's also got a very thorough data dictionary associated with it. So all of the data contained within the N3C Enclave is from EHR data. So it's patients' EHR data, which means it can come from Epic, it can come from Cerner, or it can come from several different medical record compilation packages. And it goes from Epic to either ProCornet, ACT, TriNetX, or directly into OMOP framework. Then it all gets harmonized together into the OMOP framework. And here we've got the N3C data enclave is where all of the data is harmonized together. It's got a little lock here because you have to have special permissions to be able to access the data. And over here, we've got individuals that can help you through all of that process. Right? The enclave is built so that data is contained within the enclave, which means you cannot export it, you cannot download it to your local computer. You have to use the N3C enclave to be able to analyze it. The backend tools that you have to use that are built in R or Python. So you need to have familiarity with one of those two software computer programming languages packages to be able to analyze the data. Okay. So N3C, is an enterprise, which means it's got lots of different groups of individuals working together at various different levels to help analyze the data, to help govern the data, and there's a regulatory component to it. There's technical infrastructure on the back end. So NIH partnered with Palantir to develop the Enclave and a lot of user-friendly tools within it to help you work with the data and analyze your questions of interest. They've also got a lot of technical and analytic support to help investigators along the way. So what types of questions can N3C help you address? There's a big giant scope and there's lots of that flexibility. So things we can answer are, do some therapies work better than others for treating COVID-19? Do these therapies differ by region? Do they differ by demographics? Can we potentially compare local rare clinical observations with national occurrences? So we've got the ability to look at regional information as well as national information. We can be able to answer, can we predict who might have severe outcomes if they have COVID-19? And can we predict acute renal failure in COVID positive patients? So think of all the things that you would typically find in your electronic health record. We've got access to that type of data and that patient data here. So any different types of questions you could analyze with your EHR data, you can use the N3C platform to address for a question specific to COVID-19 research. Down here we've got, for kids, can we compare rates of infectivity before and after school reopening? So that means we have pediatric data as well as adult data. We've also got additional data resources that have been connected to the electronic health record data as well. And I'll talk a little bit about some of the other connective data that has been brought into the N3C Enclave. Okay. So what does this data actually look like, and how much data do we have? So right now we have about 1.22 million positive patients, positive cohort, positive COVID patients within the N3C Enclave. Those data come from 50 sites within the greater US. Sites are frequently an academic medical center, but they don't have to be. We've got roughly 4.9 million patients included within the Enclave. So that means that we've got COVID positive patients as well as COVID negative patients. And this 4.96 million patients means those patients have had a COVID test. 1.22 million of them had a positive test, and the others had a negative test. We have 5.8 billion rows of data, so we're collecting more information than just whether or not you've had a COVID positive test or not. We're collecting all the information in your electronic medical record, which means we've got information on 287.3 million procedures, 949 million drug exposures, 2.6 billion lab results. And down here, I've noted that we've had multiple phenotypes in the N3C Enclave. The first phenotype was that we gathered data on anybody that had a COVID test period. Whether that test was positive or negative, we captured that individual. That grew enormous because there were lots of negative tests being done. So we revised the phenotype into a phenotype 3, where now the information we are pulling in is COVID-19 positive patients that are being matched to control patients, which means we are matching each COVID positive patient to 2 negative patients at the same site. And these patients are matched based on their age, race, gender, and ethnicity at each of the 50 sites before they're brought in. So the matching is actually done at a site-by-site level to try to get a better idea of matching locally versus regionally. And I've also got a little star here on the number of COVID positive patients. And that's because there's not a great definition, a 100% widely accepted definition of what it means to be COVID positive. So here we've defined it as the number of distinct patients who have had at least one positive result for any COVID-19 lab test, whether that was a diagnostic test or an antibody test, or they had a diagnosis of the ICD-10 code for COVID-19. Okay. So this is just giving you a snapshot of what some of the data looks like. On the left of the figure, we've got the COVID positive individuals. On the right, we've got the COVID negative individuals, and we've got this defined by range. Sorry for the blurry number of age here. I tried to blow this up, and that's what didn't copy over right. But you can see that there's a roughly equal distribution of males and females in each of our 2 groupings, and we've got in the range span of ages for the positive versus the negative individuals. We've also got information on those what their comorbidity is for a lot of these individuals. So here I'm showing part of our dashboard indicating those individuals that have comorbid conditions, those that are considered to have mild COVID-19 versus those that have had more severe COVID-19 and have had to be hospitalized. What's the percentages of those individuals that have had these various different comorbid conditions? So you can see there's lots of pieces of information in this puzzle and in this data set that we have access to. Okay. I'm also discussing here that there are multiple different tiers of access to the data. So Ohio State University has a data use agreement, which means every one of you will be able to gain access to at least one of these levels of data if you would like. There are 3 different levels here with different stringencies and different restrictions on who can have access to it. So there is what we refer to as level 1 data, which is synthetic data. That means that it's not the true EHR data from each patient. Instead, it's data that has been computationally derived to be statistically similar to that data. Anybody can have access to this data, which means that citizen scientists can utilize it, i.e. people that don't work at a university but are interested in doing COVID-19 research. So this probably isn't what the majority of you are going to be interested in. You're going to be interested in either the level 2 or the level 3 data. And the level 2 data is what we commonly refer to as the de-identified data. Basically, that means none of this data has patient names in it or actual addresses. So we've removed all of the 18 PHI from the data. This level 2 data has additionally dates of service instead of the actual date of your test or the actual date of whatever lab or surgery is performed on you. The dates have been shifted in some capacity to protect patient privacy, which means the dates you will see if you use the de-identified data set can be shifted either 180 days pre or up to 180 days post. And they're randomized shifting. So if patient X has their date shifted by 5 days, every operation, every procedure, every date of that patient will be shifted by 5 days. Patient Z might have their date shifted by 90 days, and every date for that patient will be shifted by 90 days. So it's to help ensure that patients can't be re-identified. In addition, we have also truncated the patient zip codes. So instead of using a 5-digit zip code for the location in the de-identified data set, we have only used a 3-digit, the first 3 digits of the patient's zip code. To access this data, you need to register with the N3C Enclave. You need to have a DUA, data use agreement, which Ohio State does, and you need to complete some minimal NIH security IT training. It's online. It takes about 10 minutes to flip through the little videos and answer the question at the end. You also need to have completed some sort of human subjects research training. So for me, this is city training. Just verify that your completion date. They just want to see that. In addition, you need an approved DUR. This stands for Data Use Agreement. So when you register and apply to access the data, you create something known as a data use request. The data use request is reviewed by individuals and a governance committee from the NIH, and they say, yes, your question is COVID related. Yes, you should be able to analyze it using this data set. Yes, you can gain access to the N3C Enclave to be able to do so. Lastly, there is what we refer to as level 3 data, which has the most security requirements for being able to access it. And it's also referred to as the limited data set. So this one has, again, all PHI removed from it, but now we actually retain the exact date of service and the entire 5-digit zip code of the patient. So if you want to be able to do research and you need the exact date of operations or labs or something that can't be date shifted, the limited data set is what you want to use. The limited data set can only be accessed by individuals that reside from a US-based institution, and they can only be accessed by institutions that have a data use agreement. The issues need the same requirements to be able to access the data. So again, you have to register with N3C, you have to do some sort of city training, you need to do the NIH security training, you need an approved data use request. Now you also, as part of that process of getting your data use request, you also need IRB approval from your local institution to be able to answer your COVID-related research questions. I've found that this IRB determination letter for me is really simple to get because it winds up being exempt status. And so, yes, I have to do an IRB application, but because it's de-identified data that was already collected, IRB treats it as exempt. So I don't have to go through the whole rigmarole of the full-blown IRB meeting to discuss it. So it usually takes, for me, about a 2-week process to get that IRB determination letter. And once you've got that IRB determination letter, then you can apply within the Enclave for your data use request to analyze the question of interest you've got related to COVID-19. Okay. So as I've said, there are several steps you need to do to get access. Ohio State has a data use agreement, so you guys don't have to worry about that. So far, we've got over 150 plus different institutions being able to access and utilize the data. And the process to access things is a little bit complicated, meaning what I'm showing you here is that individuals sign on to say, I'd like to analyze this data. Here's my research question that I'd like to analyze the data for. So then you are assigned within the Enclave a research project. That research project is directly tied to what level of data you will be utilizing. So the N3C Enclave, once you get access to it and you get access to your project, you will automatically be granted access to the appropriate level of data that you have applied for. There is a user code of conduct for being able to do research with any of this data. And that user code of conduct means you can only use this research, use this data for COVID-related research. So you can't decide to say, oh, this is a fabulous research, and I'm interested in something on hepatitis C virus and lung cancer. I want to just look at those two things. That's a no-no unless you are framing it in terms of something related to COVID positive or negative individuals. Okay? You have to promise that you will not attempt to re-identify people, institutions, or populations. So all of the 50 sites that are depositing their data are assigned some numeric code. They are not identifiable anywhere in the system of, Ohio State deposited this data. University of Texas Medical Branch deposited this data. We are just assigned some numeric code, and Ohio State might be 120 and UTMB might be 209. It is just a site code that is randomized and consistent. You also have to agree that you will not take screenshots of row level data or results, or you will not record any calls that show row level data. Everything I've shown you here is all on our publicly available site, so anybody can access it. So I haven't shown you anything specific. I'm going to show you a couple of other screenshots from the Enclave in a bit, and those do not contain row level data. We do want you to publish your results though, so that means that there is a data download policy and a separate committee that you can go through for approval to share figures and results from the work you've done. So if you're interested in sharing what you've done to a group of individuals, you have to go through a committee to get approval to do that. And we like you to attribute N3C properly. So they have, N3C in general has been very expansive in who they credit for working and any publications they do. So they want to make sure that the 50 sites proposing data gets credited. They want to make sure that every individual on the team working through the process gets credited as well. Okay, and these are part of the community guiding principles for how to work with that and through that process. As I said, there's publication and exporting of results. And yes, you can do that. They encourage that, but you have to work through the publication committee to do that. Okay? And I've mentioned there is also, in addition to the EHR data from these 50 sites, there is also external and supplemental data within the N3C Enclave that you can get access to. And I'll talk about what some of those are in a few minutes. But I thought I'd just go and show you, once you've got access to the N3C Enclave and you're interested in starting your own projects, this is the environment that you will be working with. And these are just screenshots of what it looks like now. Each of these 6 things here are buttons, and they open up new pages, which means the individuals associated with N3C have done a lot of work to help you and provide support for every step along the process. So there's a support button if you've got help, if you've got any questions along the way. They've got a ton of training materials. They've got OMOP workthroughs. They've got how to do this, how to do that, how to access some data. What does the data mean? What does the data look like? So the data here is not just in Excel spreadsheet format. It's actually an OMOP framework format, which means it's, at least for this statistician, a little confusing and backwards, and I had to do a lot to understand how to work with it. The informaticians who are more familiar with the OMOP structure have had an easier time, but they don't know how to do the stats analysis on it. All of these 3 buttons here, data use request, my projects, and explore projects, are all about things associated with you, projects you want to do, questions you want to answer. So they're meant to be quick, click this, you get provided with this information. My projects are the different pockets of projects, different COVID questions that you want to answer. One might have level 3 access to the full limited data set. One might just have level 2 access to the de-identified. And then over here on the left, we've got all of the pages that you pull up to do separate things. So projects and files takes you to a listing of all of the different projects that you have access to. And you can also just see a title of what everybody else is doing within the system. Things like contour reports and code workbook and code repositories are links to all of the analysis tools that can help you throughout your data analysis pipeline. Okay, so this is a screenshot of what the project folder might look like. This is saying I've got access to a social deprivation index, and there's other external data sets and projects going on. Ignore the last updated information for now. We can also see what a data catalog looks like. So this is the listing of all the data sets available within the N3C Enclave. You can see there's tutorials, external data sets. If you've got access to the level 2 data, you'll see a de-identified data and other things along the way. This is a snapshot of what is known as Contour within the system. Excuse me. Contour is meant to be sort of a GUI simple statistics operator. So it can do a lot of, create a lot of graphics. It can do a lot of data filtering. So basically you can use Contour to help you identify your patient cohort and filter out to just those individuals that you are most interested in, as well as see a lot of things visually with it. This is an example of a code workbook. So how the Enclave works is you do things in snippets, and there are snippets of this and that. So over here on the left, we are taking 3 separate data sets. So I might have the person level data set that I want to combine with a drug exposure data set that I might want to combine with an external data set. And so I'm starting with all those different pieces, and I want to put them together in a way that I can create my cohort. So that's what's done here with all these different lines, is I've created my cohort for patients within the Enclave that have HIV that I then want to do analysis on. So my code workbook is combining all of my little snippets of code to do each piece of the process along the way. And you can see how they are all tied together so that you can backtrack and change a simple thing in code. As I mentioned, the code you can either write in R or Python, and the preferred flavor of R and Python is Spark R or Spark Python, combined with some potential for SQL as well. Okay. So I mentioned the back end for this common data model was OMOP. OMOP stands for the Observational Medical Outcomes Partnership. And it's pretty much the most extensive data dictionary that has been out there, which is why OMOP was chosen. And it also has a lot of tools built by the Odyssey Collaborative to be able to utilize data in that framework. So that's why that framework was chosen as opposed to another one. OMOP is, it was designed for analysis purposes, not billing or other things that Epic and a lot of other custom design software was. So the nice thing about OMOP is it was designed for the purposes that we're trying to use it for. We're not left with Medicare claims data that was obviously designed for billing purposes that we're trying to use for another purpose. It's got lots of data protection uniquely built into it. So that was a positive as well. And the structure of OMOP is that there are domain tables. So that means there are person tables, there are event tables, there are lab tables, there are drug tables. And so all of these different tables have to include a person ID as well as a date, so that you can connect one table to another table and trace that person's record across the entire space. Okay? So this is an example of what a drug exposure table might look like. And this is an example of synthetic data. So while this is row level data, it's synthetic data and it's not true COVID positive patient data. But you can see that there's a person ID, there is a drug exposure ID, there's a drug concept ID. So this tells you the drug concept ID directly relates back to what drug do they have. So you can use the Odyssey tools to identify what this number means in terms of what drug have they been taking. Okay. There are lots of OMOP concepts that have been leveraged from national and industry standards, which is good. And so that means there's also a lot of tools for working with those, which means there's a good standardized vocabulary hierarchy, which if you've ever tried to connect two different data sets, you know this is extremely important. And so that's what we've got to use here. So here I'm just showing you an example of the OMOP structure for pneumonia. There's potentially multiple different codes for pneumonia, depending on whether you're using an ICD-10 code, an ICD-9 code, a mesh ID. All of those have been combined together into one OMOP concept ID. So that is nice to be able to say, okay, all these 10 different ways of saying one thing, we say them as one thing in OMOP. And this is an example of what we're saying when we say, okay, bacterial pneumonia, that's a type of infective pneumonia, which is actually a pneumonia, but pneumonia is a certain type of pneumonitis. And so each of these has a different characterization within the OMOP terminology that you need to be aware of and know how to work with. N3C, as I said, contains a lot of these OMOP data tables. So this is just a snapshot of what some of them are. There's a person table, which contains year of birth. Again, that might be date shifted, depending on whether you're using the de-identified data or the limited data set. Contains a person's gender, race, ethnicity, and either their 3-digit or 5-digit zip code, depending on what level of access data you've got. There's a visit table, which contains information about a start and an end date for various visits, whether it's just a clinic visit or a hospital visit, whether it's an inpatient visit, an outpatient visit. The care site and the provider, meaning the care site would be the randomized number associated with a site reposing data. Provider may or may not be included. For both of these, the individual institutions submitting the data is anonymized as a number, but we might not know they were sent from Clinic 1, Clinic 2, Clinic 3, Hospital 1, Outpatient Center 3, Rehab Center 5. A lot of that information is actually missing. Same with there's a provider table. The provider has the gender as well as the specialty of that provider. For a lot of instances, that data is missing. Care site are things like, is it an office? Is it in the hospital? Is it the ER? Is it a nursing home? Is it a skilled rehab facility? And then we also have information about payer. So are these individuals Medicare, Medicaid? We also have information about their individual insurance, whether they have private insurance or not. And in some cases, we do have information about who their insurance provider is. We also have information about their procedures. So what things have they had done to them, either in the hospital or previously. So the data within N3C for each patient is retrospective back to January 1 of 2018. So we've captured everything that is known about that patient within the individual EHR from the current date that the data is being reposed into N3C all the way back to information on that participant up to January 1st of 2018. So we've got information about all the procedures they've had done within that time span, the date of it, whether that date has been date shifted or not. We've got information about any devices they've been utilizing, any drugs they have been prescribed. We don't know whether they've taken them or not. We just can tell you whether they've been prescribed. Any measurements or labs that have happened to those subjects, as well as the date of those and what the resultant values, the measurements are from those. Any conditions or diagnoses that are within the EHR and known on those patients. And we're also trying to capture death information. But death information, as a lot of you might know, is somewhat problematic because the hospitals don't always record death if the person died outside of the hospital scenario. So if the person died at home, hospital's not going to record that. It might likely not be in a individual's EHR. So we have to go through government records, which may or may not be updated monthly or every 6 months. So for death information, there's actually a lot of missing data there simply because that information is not very well captured in an individual institution's electronic health record. And sometimes we might know the cause of death as well as a date of death. But again, these are asterisks, so they are spotty and sometimes missing. I mentioned there are a lot of, we got a question here. What data is submitted to the system by institutions? How long does it take to become included in the sets? And what's the lag time? So what data is included is your patient record. What is not included is image data or text data in things like doctor's notes that would require natural language processing to import. So for us, we use Epic Clarity, and it's basically data contained in Epic Clarity that then gets sent to Tridentics. So it's not everything contained in the patient record. It's not pathology images. It's not MRI scans. So anything image related is not currently captured. Anything written in notes is not currently captured. If it has a procedure code, diagnosis code, lab results type thing, those are captured. The lag time varies from institution to institution, but right now we are currently requesting that every institution update their data every 2 weeks. So if they are approved and through the pipeline, the majority of the 50 data sites that are currently within the Enclave are providing new data every 2 weeks. The institutions that are in the pipeline, meaning they want to transfer data, but it's not completely in the Enclave yet, are still working with individuals to suss out all the bugs and being able to do so. So sometimes that process takes a month, sometimes it takes 3 months. It's just depending on how many people at the institution have the know-how and the skill set to be able to do this. But the Enclave is refreshed every Friday afternoon, meaning that the ability to have updated new data happens every Friday afternoon. Also, everything is version controlled. So if you are in the middle of an analysis using your data and a new version comes out, you can still opt to continue your data analysis with the prior version or the prior 4th version. So it's up to you whether you choose to go to the new version or not. How accurate is death data if death date is non-missing? So If they died in a hospital, we know that information. There is a team working to try to harmonize death date again, but that's why I had it put with 2 asterisks, is we know it's problematic. We know it's problematic because, again, as I've said, not everybody dies in the hospital. So there are similar hiccups you have as you'd see working with VA data. Sometimes you get prescriptions after a death date and you have to deal with filtering those out because you know, okay, patient died, that data just didn't get processed in the system quite as well. So back to supplemental data here, this is just a snapshot, it's not inclusive, but we've got social deprivation index included with it. There is healthdata.gov COVID policies. So when did certain areas go on lockdown? When did certain areas allow kids back in school? There's SafeGraph data. There is some level of census data, and we're currently working on adding more census data to it. This is one of the tools that you can utilize to help define your cohorts, basically identifying OMOP concepts that are important to questions of your interest. So these might be, I want to be sure I capture somebody's blood urea nitrogen levels, and do I want to do that in their raw form, or do I want to capture the creatinine level for their urine panel, things like that. So this is where you build up all of the pieces of information you want to include in your analysis. And so I've got OMOP harmonization. So not only do we bring data from those 4 different components, so whether you upload your data in Trinetics format, ACT, PCORnet, or OMOP, they're all slightly different structures. We've got a back-end team that is working to harmonize the data from those different 4 sources, meaning if your university records temperature as Celsius, and my university records temperature as Fahrenheit, there's a back-end team to merge those 2 and make sure the data is more consistent for the researchers. So there's a lot of back-end harmonization that goes on that's already pre-done, so that hopefully by the time you get the data, you have a little less of these bugs that you have to work out, similar to what you'd see with VA data or Medicare claims data. Okay, so this is referring to the death data question that somebody asked. Not all of the common data models require you to submit death data. They don't require the date of death. So you can see that Odyssey if you submit your data as Odyssey framework, then yes, death date is required. But if you submit your data in the PCORnet framework or the ACT framework, you're not required to submit death data. So you may or may not date data. So you may or may not see that within the Enclave, depending on how that particular institution submitted their data. We are working on trying to change all of this to WISE across the board, but there's still some behind the scenes stuff that needs to get done for that. Okay. So as I said, there are also, in addition to the data repository having COVID positive information on patients, well, there's many different ways to identify COVID positivity. And we've tried to incorporate all of them. So we've used PCR tests, we've used positive antibodies, we've used ICD-10 codes, and we've also got the ability to look at, are they mild COVID or more severe COVID by, were they hospitalized or not? Point. This just is trying to show you a snapshot of things that investigators are interested in getting correct within the system. So I know there's already been a question about death status, and this is the top priority on being able to get all that information and all that information correctly. And this over here in this column shows you how difficult is it actually to do that piece of the puzzle. And some are challenging, inpatient admission correctly identifying it versus a little less challenging of family relationships. As I've said, all tables have a data partner ID column in them, but we don't know, it's sort of a de-identified fashion. We don't know that this data comes from UTMB. That data comes from the University of Nebraska Medical Center. So that piece of the puzzle is redacted. And N3C is meant to be more than just an individual investigator looking at something. It's a community, which means we participate in teams of clinicians on a team, biostatisticians on a team, informaticians on a team, all working together to answer various questions. We call those domain teams. There are currently well over 20 domain teams that are working on specific questions. So this is the overall structure. There's lots of domain teams here working on various pieces of the puzzle. So what I suggest is if you're interested in utilizing this data, look at our website, which is covid.cd2h.org. Look at the different domain teams, see if any of those are related to potential questions you might have. Join a domain team to get familiar with the data and how you work with it, and you might be able to help them analyze a question, or it might spur off your own question that you could then request your own data use request for. So I think that's all I've tried to sum up. Most of what I've said here is covered in an N3C Orientation A session, but there's also an Orientation B session which you can register to join, where staff will go over more of the analysis techniques and tools for working with the system. Is there another question here? Is there a count threshold for the N3C data, since all data go into the Enclave? Is potential overlap of patients addressed? So there is not a count threshold, meaning one of these slides I've showed you the number of data in the Enclave currently. Here, this slide shows you the number of positive patients and the number of total patients. We don't have a top-end cap for that. So NIH is currently working to get us access to some more data clusters, computer clusters, so we can process the analysis even faster than we currently are. Since all data go into the Enclave, is there an overlap? So we have a separate team on the back end that is trying to work with the entities to make sure that John Doe at one place is a different person than John Doe at another place. And if they are the same person, to try to link those up. So thankfully right now, since most of the data is coming from academic medical centers, their spread is fairly large. So we only really have the overlap of patients is if you see me in Kentucky, and then I later decide to move to Virginia, and I have a COVID negative test in both locations. We're trying to do the back end better to connect those dots so that we diminish the overlap of patients. So right now, there's not a, we don't think this is a big issue. A few more minutes for any other questions, if anybody's got them.
This is a great talk, Heidi. Thank you so much. Very informative. And it's interesting. Every time I thought of a question, 2-3 slides later, you answer it. So yeah, very awesome. I still have one more question. Are you still, or is not you, but is Enclave still kind of trying to get other centers or institutions to join? Are they still kind of growing in terms of number of Yeah.
Yes, we are. So I can tell you that a month and a half ago, there were only 39 sites that were submitting data. Now there's 50 sites submitting data. So we are increasing our number of sites that are submitting data. We are also trying to increase the capacity for data that is being submitted. So that means we're trying to encourage institutions to send their NLP text data, to send their image data. And we have a couple of pilot projects working to see how that we could make that happen in a fashion that could be de-identified. So what you see in here now will definitely grow over time. NIH also recently had the call for post-acute sequelae to COVID-19, and as part of that call, it was also to expand the types of data that are being collected. So survey data, population health information, more information related to disparities and economic impact and things like that to bring in more data to the system. So hopefully one day there will be lots more types of data that we can access.
Okay.
Right.
Any other questions?
Doesn't look like it.
All right. Well, thank you so much. And, well, I hope this is a very kind of productive and productive in terms of the manuscripts and projects that come out of this collaborative.
Absolutely. And if anybody has any questions, they can shoot me an email here or go to the N3C website, which is down here on the top.
Perfect. Well, thank you so much. Thank you, everyone. Thank you.
Thank you.
Hi, Heidi.
Hi, guys.